Okay, good afternoon, everyone. Looks like we've got a good number of people who have come in and gotten connected. So let's get started because we have lots of good content to get to today. So thank you for joining us today for our community forum. We're talking about an environmental law lens, an environmental law lens on the social determinants of health. My name is April Lepler, and I am the engagement coordinator for the Healthy Great Lakes program at the Canadian Environmental Law Association, or CELA. We are co-hosting today's session with the Community Advocacy and Legal Center, and Lisa Turek of CALC will introduce herself and the Community Forum series in just a moment. We've been very much looking forward to this conversation today. We really appreciate all of our panelists taking the time to share their knowledge with us today, and we're especially grateful to all of you in the audience for taking time from your busy schedules to be in conversation with us about this important topic. I'd like to start with a land acknowledgement. I'm calling in today from Guelph, and I'm grateful to live on the banks of the Speed River on the traditional lands of the Attawandaron peoples, stewarded in the past by the Haudenosaunee and Anishinaabe peoples, currently under treaty with the Mississaugas of the Credit First Nation. As a settler, I'm committed to learning and practicing reconciliation based on the recommendations of the Truth and Reconciliation Commission. And you're welcome at any point to introduce yourself, share your own land acknowledgement if you like, using the chat box. That feature is available to you. So I know we're all really experienced with Zoom these days, but just a few quick housekeeping notes. We're using the Zoom webinar platform today, which means that your mic and your camera are all automatically turned off. But we do very much want to be in conversation with you today. So there are two ways you can connect with us. One is through the chat box, and we encourage you to use that to introduce yourself, to share any resources or comments, or share any stories or anecdotes that you have. You can use the chat for that at any point in the session. Also, if you have any technical issues at all, feel free to send me a private chat using the chat box, and I can try to help you out with that. If you have questions about the webinar for our panelists, about the content, we ask that you use the Q&A feature. So if you scroll over the bottom of your Zoom window, you'll see a small Q&A icon, and you can pose your questions in the Q&A box. Our panelists are able to answer those in writing during the webinar, and we'll also save some of those for the Q&A session at the end. So we are recording today's session, and I'll just note that we won't be reading any of your names aloud during any of the discussion periods, and you do also have the option to pose questions anonymously if you'd like, and neither the Q&A nor the text will form part of the recording. I'll be introducing each of our speakers today as we move through our session, but I did just briefly want to introduce Jocelyn Radcliffe. Jocelyn has graciously agreed to join us today to lend a healthcare perspective and help us pose some questions of our panelists throughout the session. Jocelyn is the new chair of the Ontario Nurses for the Environment Interest Group of the Registered Nurses Association of Ontario. This group works to build awareness about issues of health and the environment and links nurses with opportunities to get involved in advocacy and activism. She spent 6 years as a public health nurse and is now completing her PhD in public health at the University of Waterloo, focused on climate change and food justice. So thanks for joining us, Jocelyn. At this point, I'm going to pass the mic over to Lisa Turek of the Community Advocacy and Legal Center to tell us a little more about her organization and community forums.
Thank you very much, April. Welcome, everybody. I'm really excited to be here speaking with you today. To give a little bit of an introduction to who I am a lawyer at the Community Advocacy and Legal Center, and I've been practicing at CALC for about 7 years now. I started as an articling student and slowly tried to make myself indispensable and never leave. Most of the work I do at the legal clinic is focused on disability appeals, social assistance, housing, but I also do a little bit of power of attorney work. And the other hat I wear is as what we call the project lead for something called our Justice and Health Partnership Project, which I'll be talking to you about today. First, I just wanted to give a short introduction to legal clinics and the work that led to this forum today. And then once I'm through that, I will be pleased to turn it over to CELA and our presenters. So my legal clinic, CALC, is located in Belleville, and it's one of many community legal clinics that are spread across Ontario. So there is a local community legal clinic no matter where you live in the province. And those geographic clinics are complemented by specialty clinics like CELA that focus on specific areas of law as opposed to a geographic community. And they often work on areas that the geographic clinics don't have the resources to cover, the expertise to cover. So most of the rest of my presentation will be focused on the work of those geographic clinics, and I will happily leave it to Sela to speak more about their work later on in this webinar. Clinics of all stripes provide services to people who are living on a low income. And the emphasis focus of our work at the geographic clinics is this idea of a roof over your head and food on the table. So the bulk of the calls we get to the clinic, the bulk of the work we do is often around tenant rights and income security issues, but geographic clinics will also practice in other areas of law with, and those areas are kind of determined by community need. So for some clinics, that might mean doing some immigration and refugee law, employment law, consumer and debt work, power of attorney work, working with seniors. In addition to providing direct legal service through information, advice, representation, and referrals, both geographic and specialty clinics do things like public legal education, so talking to people about their rights, community development work, law reform, and systemic advocacy, so trying to get things changed at their sources, laws changed at their sources. Legal clinics generally don't practice family law, criminal law, long or short-term disability, real estate, or estates work. And the reasons for that is varied, but do know that Legal Aid Ontario provides service to people living on low incomes with family and criminal law work, and the rest of the areas are just not generally the focus of legal clinics. So what led a legal clinic like mine to start to talk about the social determinants of health? Well, I started at the legal clinic in 2013, and at the time, much of my work was focused on disability appeals. So trying to help people who had been denied provincial disability benefits to access those benefits. And that necessarily involved talking to healthcare providers. And I also spent quite a bit of time working on housing cases where health issues would come up. People would bring up problems with mold, with rats, with bats, with bad well water, housing that wasn't safe or adequate for them because of a disability. And I knew that these same people that I was working with, that they were very likely seeing their healthcare providers regularly, and probably for many of the same reasons. There was a lot of overlap in what we were doing. And not only that, but in all likelihood, they had been talking to their healthcare providers about these problems, discussing these issues long before they ever came to me. And I knew that the longer these problems went on before they got to Calc, the worse they tended to get. So around this time, our fabulous executive director, Michelle, who I think is here today, told me about the social determinants of health. It wasn't a term I'd ever even heard of before as a lawyer, but it clicked right away. And I could see how intimately tied the social determinants of health were to legal rights, to the point that what a healthcare provider would call a social determinant of health issue, I would say as a lawyer, was actually an access to justice issue, was a legal problem. Things around housing, things around income, those are important social determinants, and had a profound connection to people's access to justice and legal rights as well. So the social determinants felt like the missing piece. It was what we needed to improve people's legal health, and it was also what we needed to improve people's overall health. And it felt like suddenly I had a language, a shared language. I knew the code word to start to talk to healthcare providers about these issues in a way that everyone would be able to understand and that would make sense. And I hope that we could work together on some of these problems to resolve them. This was a chart we created fairly early on in the work of the legal clinic around trying to puzzle out how the social determinants and legal issues were connected. So to take the example of tenant rights tied to a number of different social determinants, including housing, but also things like disability, early life, even gender and race. The types of work that the legal clinic could do, legal help that we could offer, was around evictions, repairs, discrimination, and harassment. And the hope was that if we could address those legal problems contributing to the social determinants of health problems, we would end up with stable, healthy, decent housing. People would feel less stressed, and maybe, we would see, or the healthcare providers could see, more compliance with treatment plans. So we hoped to work with the healthcare providers to identify these connections, which we knew were numerous, and then to get those people referred to us at the legal clinic so that we could address the problems at their source. So what did we do next? We started to read and to research more about this law health connection, and the term medical legal partnership started to pop up in what I was reading about. And one of the first things I learned was about this physician, Dr. Geiger, who worked in Mississippi in the 1960s. And his work at his community health center was actually quite interesting. And one of the things that he did was he started to see people who had malnutrition as their presenting health problem. So he started prescribing food. He would actually write prescriptions that people could take to the grocery store, to the community health center, and then bill their purchases back to his health center. And apparently his funders were not super impressed with this idea at the beginning, asked what the heck he was doing and why he wasn't prescribing, treatments or medications or things like that that they were more used to. But he just responded, that the last that he had seen in his textbook, the treatment for malnutrition was food. So that was what he was going to prescribe. And he went on to hire a lawyer to work at his health center who dealt with civil rights issues, and particularly rights issues related to housing. So kind of initially starting this idea of a medical legal partnership, something that brought health and law together in a concrete and more formal way to address these problems that overlapped both areas. So at the time we started the Justice and Health Project at our legal clinic, this medical legal partnership movement was growing in the US, but it mostly involved lawyers who were working on site at healthcare provider offices, much like the lawyer at Dr. Geiger's clinic. And this was working. So the research was showing that there were decreased healthcare costs, decreased healthcare spending, particularly related to patients that were complex, high cost, high use, fewer emergency room visits, hospital admissions and readmissions, people who could comply with the treatment that was recommended to them, people who were less stressed, mental health started to improve, people even accessed more preventive care services like smoking cessation and dietitian services. And kind of the most interesting one to me was when I saw that healthcare staff satisfaction improved when they worked as part of a medical legal partnership. And initially I couldn't quite understand why that might be, but I worked with a couple of nursing students fairly early on, and they said, it makes sense to them because they had been trained, they had heard about the social determinants, those were no secret, their importance was no secret, but they'd never really heard what you could do to address those problems until they worked at our legal clinic, and then saw that working with a legal clinic, that was a solution to social determinants of health problems. They felt that their hands were tied before, and now they could kind of see the light, they could see an opening to do something about these issues. So at the same time, research was coming out that showed that people would go just about anywhere before they would talk to a lawyer, which maybe not surprising. I like to think that at legal clinics we're kind of a different brand, but they would turn to friends, they would turn to family members, they would turn to trusted intermediaries is what we started to call them. So helpers in the community, social service providers, healthcare workers. And so it became pretty clear pretty quickly that if we wanted to do this work and have a lasting impact and really improve access to justice and improve people's health, we needed to partner with healthcare providers. So we started something at the legal clinic. We gave it a new name. We started to call it the Justice and Health Partnership Project, really just to reflect that we weren't going to follow this model of having a lawyer on site all the time at a healthcare provider's office, because that wasn't how the legal clinic system in Ontario was set up. And we actually thought we could do something different and possibly even better than what was being done in the States. The legal clinic system is robust. It exists everywhere across the whole province. And we have a network of colleagues and specialty clinics that we could rely on to actually provide service to more people if we worked through the legal clinic system. So our Justice and Health Partnership Project, these are just some facts about it. The focus was really on access, so improving people's ability to get to us in a timely fashion. Focus on services, so adding in things like power of attorney services, which our healthcare partners told us were important and an underserved area. and then a focus on training. So helping healthcare providers to learn about this connection that we had identified, to identify the social determinants of health issues as legal issues and send people to us early. And we worked with healthcare providers to make those trainings as effective as possible. Over the last 6 years, we've helped probably, I think this number is actually from last year, so it's well over 1,100 people at this point. 50% of the clients that our legal clinic has seen through this project have come from rural areas, which are traditionally underserved. 50% of those people had never heard or did not know about the legal clinic before they were referred by their healthcare provider. We've built stronger relationships and really seen an improvement in our own ability at the legal clinic to support clients with complex needs or intersecting health and legal issues. And this is just such a far cry from the total 30 referrals we received the year before we started the project from healthcare providers in our area. Really has made a huge difference. Our healthcare providers generally have had good things to say about the project, and I think I'll just very quickly wrap up, or almost wrap up, just sharing a story so that I think illustrates this connection and the way that the working together results in the best outcomes. And it's a story that was relayed to me by a paramedic who worked in a northern part of our catchment area, and he said that, you know, every day for close to a month, he was getting called to the same woman's apartment because she was calling 911 and saying she was having a heart attack. So he was picking her up, they were taking her to Emerge, they were doing tests, and what became clear fairly quickly is that she wasn't having heart attacks, she was having panic attacks. But she couldn't be persuaded that it wasn't a heart attack. So they kept taking her back, and this was the result over and over. Finally, close to the end of this month, the doctor who saw her happened to also work at the family health team and was part of our Justice and Health Partnership project. And he said to her, "What is happening before you have these heart attacks, these things that you think are heart attacks? What's going on?" And she said, "Well, it's funny that you mentioned that, but now that I think of it, every time this happens, it's right after my landlord has come over. My landlord is really difficult to work with. He will come in, he is rude, he barges in without giving me notice. He's told me that he's going to make me give away my dog. He's issued a no trespass order against my son who helps me with groceries. You know, he's just really been making my life pretty difficult. And so now, you know, now that you mention it, really these things, that's what's happening right before I have this heart attack." So he referred her to the legal clinic. I'm sure whoever talked to her at the legal clinic, the total time we spent was probably about 30 minutes to speak with her, to write a letter to this landlord saying that most of that was quite illegal. And he backed right off, and the paramedic said that he never went back to that woman's apartment again. And this was like 3 years after that had initially happened. So, you know, all the treatment in the world for this woman, for her anxiety, for the panic that she was experiencing, wasn't going to resolve that underlying social determinant issue, the housing issue, but legal help could. That's what could make the difference. So that just leads me to a quick conclusion here, quick wrap up of how this all connects to this forum. So one of the things we noticed as part of this project is that training piece was super important, and we wanted to create more online resources for healthcare providers that spoke to this connection and to some specific legal topics. So we were lucky enough to get a grant from the Law Foundation of Ontario to create those resources, but also to host community forums like this one, where we could talk with healthcare providers about this connection and do that together with other legal clinics across the province. So I'm really excited and happy to do this with CELA today. I hope that, you know, this will do a little bit to spread the word about the potential of this work, and also encourage healthcare providers to reach out to local legal clinics and to specialty clinics when they identify issues that seem to fall in this category of overlap between our work and theirs. And so with that, I will turn it back over to you, April. Thank you.
Thank you so much, Lisa. Those are such great anecdotes. And I love the line, prescription for malnutrition is food. So simple.
Really is, right?
Okay, so if you can pull your slide deck down, Lisa, and Crystal Ann, if I can get you to put our deck up, I will take a moment and introduce Theresa McClenahan before I pass the mic over to her. So Theresa McClenahan is the Executive Director and Counsel at CELA. It's over 30 years practice in environmental law, and Theresa holds an LLB and a BSc in geology from Western and an LLM in constitutional law from Osgoode, as well as a diploma in environmental health from McMaster. She was called to the bars of Manitoba and Ontario. Focusing on environmental health and environmental safety, particularly in the areas of energy and water, Theresa has practiced public interest environmental law, both in private practice and then at CELA, as well as having been an advisor to the Ontario Minister of the Environment to assist with implementing the Walkerton Inquiry recommendations. Among other boards and advisory committees, Theresa is a co-founder of the Low Income Energy Network and remains on its steering committee. And so now I will pass the microphone over to Theresa to tell us a little bit more about CELA.
Great, thanks, April. And I will leave it to you to advance the slides when we need to do that. But thank you,
and if you
everyone.
Can go to the next slide. Sorry, Theresa. Crystal Ann has control, not me.
Right, and I don't have the master deck, so you'll have to.
This is all you need, just this one. This is it.
The puppet in the background. So yeah, thanks everyone for joining us, and thanks for that incredible welcome, Lisa. And this is quite exciting for us to join one of our sister clinics for this program. What a brilliant idea. Yeah, that slide that Lisa had about the social determinants of health is a really great one. And CELA's work is not just around the piece at the bottom that she showed that had the 10% environmental issues, but also almost every single one of the your life issues above that. And that's what really sets us apart from many other environmental NGOs because we are a legal aid clinic and we're founded with social justice as one of our framing approaches to the need for a clinic and the need for this work. And so we're one of the specialty clinics that Lisa described in the system. That means we have a province-wide mandate for representing clients and providing summary advice. And then we also, as she indicated, the general and specialty clinics do, we work on public legal education and law reform, improving those laws that we work with. And we especially focus on things like the right to participate and transparency and making sure that decisions that are going to impact somebody's home and their surrounding environment are decisions they can know about and have a say and try to influence. So we're just over 50 years old, 51 years old, and have been funded as a specialty legal aid clinic. For over 40 years, we were one of the pilot clinics in the 70s, and we're so grateful that we have the opportunity to practice environmental law in a social justice framework. So I'm going to leave it at that, but I hope that what we have to provide to you today is useful in all of your own areas of work and practice. And we're going to be very much looking forward to engaging in the conversation and exchange of ideas today. So back to you, April.
Thank you so much, Theresa. And I'll just say, speaking of environmental impacts on health, I seem to be still suffering from hay fever despite the fact that it's the end of October. So if I sneeze in the middle of our presentations, I apologize. Crystal Ann, can you go to the next slide? Thank you. Okay, so just a quick review of our agenda so that everyone has a sense of what we're talking about today. So we've done our introductions already. In just a couple of moments, I'm going to pass it over to Kathy for our first presentation, followed by Theresa. Then we should be about at the midpoint of our time together by then, and we'll take a short break so that you don't all have to sit in front of your Zoom screen for a full 2 hours. Then we'll come back and hear from Faye, and then we're going to have some time for discussion. And I'll just note our format today. What we're going to do is each presentation should be about 15 minutes. And then we're going to have about a 5-minute Q&A period after each presentation so that the questions that you have about that presentation can be addressed right after it. So as we're going through those presentations, if you have questions about the content or you have things that you want to share, you can ask your questions in the Q&A box. If you have any sort of anecdotes or things that you want to comment on about the presentation, feel free to use the chat. So that distinction is questions for our panelists go in the Q&A, resources, ideas, comments, experiences please put in the chat. And if you get it wrong, don't worry about it. That's what we're here for. So for a few minutes after each presentation, we'll be pulling some of those questions to answer. Jocelyn's going to be doing that for us, and she'll also share some questions from her perspective. Okay, so that's what the agenda is going to look like. You can just leave the slide there for a moment. I'm going to just share 2 polling questions with our audience to get a sense of who we have on the line. So you should be seeing a question here that asks what sector you represent. So hopefully everyone can pick their sector. We did our best to try to capture most of the folks we thought we'd have on the line, but I'm sure we didn't get them all. So there is an other category there. And if you find yourself in the other category, please let us know in the chat box what kind of work you do. We'd love to hear from you. And yes, great question in the chat. This presentation is being recorded and we will be posting it on our website. So you'll all get an email after today's webinar with that link, but it's on the same event page on our website that you used to register for this event today. So you'll get all of that in your inbox and you can share it out with all of your colleagues. Okay, so let's share these results back with you so you can see. I am thrilled to see that we have environmental organization not as the #1 in our audience, as we often do. I'm so glad that we have different perspectives in the audience today. So we're seeing about 15% of our audience as community and public health sector, lots of folks from the legal community, some academic and students, some government, some acute healthcare provider. Yeah, great point. We always debate whether to put First Nation on this list, and I apologize if it was insensitive of us not to. I always debate whether that is a sector or not. So I appreciate you weighing in the chat there about that as well. Thank you. Okay, and definitely a few others, so please share those in the chat as well. Thank you so much. One other question that I have to ask is location. We just would love to know where you are. So I suspect most of our audience is Ontario, which is why we've broken it out by regions of Ontario. And then we have Canada outside of Ontario, United States, and who knows, perhaps we have someone from further abroad. So we have an other category there. So just give you 5 more seconds or so to weigh in. Okay, it looks like most people have answered, so we'll share this back so you can see where we're from. So some folks joining us from outside of Ontario, which I'm thrilled to see, and then divisions across Ontario. So welcome everyone. All right, so without further ado, at this point, I would ask Crystalline, can you advance the slide, please? And our first presentation today is going to be from Kathleen Cooper. And Kathy has done environmental health and policy research for over 30 years and joined CELA in 1987. As senior researcher at CELA, she provides casework support to environmental litigation files and has directed several law reform campaigns. She has conducted extensive research into the effects of environmental contaminants on fetal and child health and related policy issues, and has authored numerous publications about child health and the environment. Recent work has included a review of law and policy in Canada concerning radon, a scoping review of the evidence of associations between early environmental exposures and chronic disease, the Healthy Retrofits report that seeks to better integrate children's environmental health protection into energy efficiency programs, and the Rent Safe Project, an initiative led by the Canadian Partnership for Children's Health and Environment to address indoor environmental health risks affecting low-income tenants in Ontario. So Kathy, if you want to turn your camera on and your mic on, I will pass it over to you. And you can just let Crystal Ann know whenever you would like your slides advanced.
Okay, great. Thank you, April. All good. I've got both on. Can you hear me okay?
Absolutely. Go ahead.
Okay. Go ahead, Crystal, for the next one. Next slide. So this is just a summary, just to ground the presentation in this research base that is quite extensive and has been developing for 30 years. I won't read out all of the health effects that environmental exposures are linked to here, but you can see they're quite significant. And of course, every single one of these impacts on health is multifactorial, multidimensional. Environmental exposures aren't always the reason for these outcomes to develop. However, we do have evidence for links that are causally related, or where there's sufficient evidence of associations in certain key areas. So for key contaminants like the criteria are contaminants, the heavy metals, some pesticides, flame retardants, bisphenol A, et cetera. It's a relative handful of chemicals in the overall gigantic number of environmental exposures that exist, where we have really solid evidence of these associations. However, there is emerging or increasingly strong evidence of links with an even larger number of chemicals and exposures, and it's why we take a precautionary and preventative approach to addressing environmental exposures. And as you probably have heard, that there's greater vulnerability for the fetus and child, particularly during fetal development, because of differences in proportion and physiology, behavior that create developmental vulnerabilities that have lifelong implications. So that's just a summary of what we ground this work in. Next slide, please. And as a result of having done all that work and addressed it in the context of our legal and policy work, we developed the Canadian Partnership for Children's Health and Environment, did these evidence reviews, we did an awful lot of work on trying to raise public awareness and empower that personal action through educational outreach materials, as well as that same strategy that Lisa described of working with service providers, trusted intermediaries, coming up with strategies, checklists, fact sheets, those kinds of things that help them do this kind of outreach. And adding to that, what very well-known concept of childproofing. There's very much a tenet of adult education that you add to what people already know. When you add new information, it's easier to absorb. And then, of course, all kinds of work on and advocacy for more research and for improving policies to address environmental contaminants. Next slide, please. So the context here is the topic today, which is that low-income children are at highest risk. With those health effects I was talking about are of concern for the entire population, but we know from solid evidence that there's even greater risk for low-income children. We know that poverty is a health risk unto itself, but that when you have situations of substandard housing, for example, you have a potential for increased levels of lead, mold, pesticides. I put radon in brackets there because it's not necessarily a low-income situation where you might have, in fact, you might have high radon levels in housing that's tighter and where there's greater energy efficiency. You also have greater potential for exposure because of the greater likelihood of using older or reused products that may contain banned substances like PBDEs or flame retardants, or for which, or phthalates and bisphenol A for that matter, or for which wear and tear results in greater release of these chemicals into dust or food or whatever. So you get that higher baseline of exposure, and then if you're doing renovation activity, it can be much higher levels in some of them, particularly lead. And then, of course, on top of that, you've got location-specific exposures outdoors, like air pollution, proximity to traffic, etc. Next slide, please. So I'm cruising over a lot of information here, but I'm basically going to focus on the Rent Safe initiative in this presentation, and just tell you about how we built on those existing KIPSHE initiatives to get to Rent Safe. And one of them was this Healthy Retrofits project, where we were approached by a young mother who had received the KIPSHE materials. Her daughter had actually in kindergarten, and she was living in housing that was renovated, old housing, an old building renovated into housing. And there was peeling lead paint everywhere because there was this notion that it was some kind of shabby chic look that was supposed to be attractive. And it resulted in very high levels of lead. and serious exposure for her children and for the entire building. And as a result of that, looking into that, we were able to resolve that situation, not just for her, but for the entire building. And it really led us to conclude that there was not a clear link being made when retrofits were happening between making sure that when you're achieving energy efficiency, you're not creating health problems indoors, often because of a lack of policy and regulatory measures to ensure that things like what I just described in that building don't happen. And what you'll notice in what I've said so far, and what was really apparent as we tried to come up with sort of the top 5 tips, for people to address these many concerns and really get at the most bang for your buck, for example, really just to make a large amount of information accessible and manageable. And what we noticed was that quite often, and we still see this, that the contaminants that we're concerned about for children and the fetus are often indoors. And then of course that greater risk for families on low income. So that led us to Rent Safe. I'm skipping over about 10 years worth of activity here, 15 years. But so next slide, please, Crystal. The Rent Safe project, I've just summarized here some of the findings that we did. The first year was some baseline research. So we surveyed sectors, of which many of you are members. So we surveyed public health, legal aid clinics, social service providers, small landlords. We did a lot of work with tenants directly. I think I'm missing somebody there. Anyway, the survey, we saw a lot of the same results coming from everybody involved. Certainly top priority issues, but structural issues in housing, mold, pests and pesticides and hoarding, those were the top issues. A little bit of variation, but often came up as the top issues. Recognition of health equity across the board. So that low income or marginalized communities are facing those compounding health determinants that Lisa described. People have very limited capacity to change those circumstances. And many important barriers, mental health issues, fear of being evicted, not knowing who to call. And so it's a big, complicated system as well. We've got, that's the other sector we surveyed, property standards and bylaw officers. So there are many people involved, many sectors involved. They all have that role to play in addressing housing conditions, and there's barriers. They have overlapping or gaps in their mandates. They don't necessarily understand the mandates of others in other sectors. But across the partners who are engaged in Rent Safe is a very multi-sectoral partnership and collaboration. And among those who we surveyed, there is a strong interest and recognition that the situation can be improved. Next slide, please. So some of our findings, we did, that was just a sense of the research we did with a range of other research efforts as well. Our findings were echoed in this report that came out by the Public Health Agency of Canada in 2018, recognizing what health inequities exist in Canada. Housing came up as a very important issue in terms of serious inequalities for low income and marginalized populations. It is also an indicator of health inequality, and there's a need to address housing in terms of both affordability and need for major repairs. They laid out the statistics on the prevalence of below standard housing, which is quite important, and the fact that if we're not meeting those housing standards, you can experience greater exposure to both physical and environmental toxins and allergens like mold. And they also highlight the need for policy interventions. So next slide, please. I'm probably going on in too much detail here. We made recommendations in 5 areas. recognition of the need to collaborate, that intersectoral capacity is necessary. We need to connect service providers across those sectors, strengthen the legal basis for that right to healthy housing, particularly municipal bylaws. Always a need for research and data and knowledge about the situation we're facing, a need for education and empowerment, and really a desire for that unifying vision of a right to healthy and adequate housing, and then applied through that equity lens to address those drivers of housing inadequacy. So of course you go beyond there. You go to the need for basic income and addressing poverty at a more fundamental level. So what we did as a result of it, and I can say that we've been successful in doing a lot of outreach and development of educational resources and drawing connections. I don't think we could say we're necessarily that successful in seeing policy change, but that's one of the goals. So I'll just describe a little bit of our educational outreach materials to wrap up. So next slide, please. So we've done several videos, a whiteboard video just describing what home means, very powerful videos by tenants' rights advocates that reflect the fact that this was very much and still is a project that involves people, tenants with lived experience, and is much stronger and more powerful as a result of that. And we put together a video called Supporting Tenants' Rights to Healthy Housing that is for service providers to recognize the nature of the problems and come up with ways of connecting with each other and resolving these challenges for tenants. The rent-safe connector that it refers to, unfortunately, is not as, it's just kind of overbuilt, over-tech tool that still needs work, but we persevere. So I'll just describe, to close out, a couple of areas of print resources that we've developed as well. Next slide, please. If you recall from the material, the summary of our findings, mold in housing was noted by everyone, including tenants, as the #1 problem that people are facing in substandard housing. So we did some really fantastic work with doctors, people in public health, et cetera, to come up with first a training podcast for family physicians about how they can support patients, and then a guide for tenants or patients living with mold, how to get support from their doctors, busting some myths about mold cleanup and remediation, and then a guide for physicians on how they can support patients, including a sample letter template. Right now, we're nearly complete in preparing a report funded by the Make Way Foundation, where we've had an expert in the health effects of mold and a public health expert in mold prevention and remediation to put together an expert report that tenants, lawyers, or paralegals can use at the landlord-tenant board, because this is not an issue where there should be dispute about the science. It's very clear. There's either causal connections or clear evidence of associations between serious health outcomes and mold, and very clear understanding of what needs to be done to both remediate mold and prevent it. So the idea is to save judicial resources and have an expert report that can be used at the landlord and tenant board, because tenants and their lawyers almost never have money to hire experts. And ultimately, hopefully that will be successful, and ultimately it will be a tool to change bylaws so that these things can be prevented from the outset. Next slide, please. This just gives you an illustration of what one of those fact sheets look like. So you can go online to get that material. I won't dwell on it. Next slide, please. And finally, I'll just give you illustration of a second fact sheet we did at CELA, not through RentSafe, but in collaboration, obviously, with people in RentSafe to address bed bugs and pesticides. This is another area of significant concern to tenants, frequent problem. And, it's often not a situation where you can use the law, because when you have bed bugs, it is an emergency that you have to deal with quickly. It needs a coordinated strategy between the landlord and the tenant. You have to eliminate the bug's habitat, prepare for pest control, and pest control options definitely vary. So you can make informed choices, and that's what this fact sheet is about. It will be, sorry, I keep looking at the chat. It's been updated 3 times because it describes the nature of the regulatory status of these pesticides, which has been changing over the last several years. But it's basically a way to help people know what their rights are, know what their responsibilities are, and help them to make informed decisions and engage in the choice of what kind of pest control occurs. And there's important context to this, I'll just finish off with this. There's been a multi-year focus at the federal level on pest control operators because they are not particularly good actors. They've been the subject of multi-year inspections. There are all kinds of reports showing legal non-compliance. So a need to keep at them. There's I won't get into the details of the nature of the non-compliance, but also add the fact that at the provincial level in Ontario, they don't have anywhere near the pesticide safety training requirements that farmers have, for example. So the context there is this work is being done sometimes in a very shoddy way, and resulting in even greater exposure. So again, even more reason for making informed choices, knowing what's involved, and knowledge is power. So I think that's my last slide, just to give you a couple of examples of outreach material that we've prepared. Could you go to the next slide? Is that the last one? I think that's the last. Yes, it is. Okay, I think I went over my time, but anyway, thank you for your time.
Not by much at all, Kathy. And it's absolutely worth it because it's such great information. I know you could do 2 hours just on this topic, so appreciate that. Okay, just before I turn it over to Jocelyn to share any questions that we have for Kathy, I just want to remind everybody, in case you signed in late, we are recording the session. So we'll post the recording, we'll post the slide decks, and we'll also pull together all the great links and resources that come up in the presentations and the chat box and the discussion, and share all of those back with you. Everyone who registered for the session will get an email with all of that. So not to worry about trying to copy down long URLs off the screen. We'll share all that back with you. Okay, Jocelyn. Yeah.
The other thing to mention, April, is that we're covering huge topics here on CELA's website. There are much more detailed slide decks that talk about what I was just talking about in a lot more detail. So we can provide links to that. So I'll put a link into the chat of that. I meant to put it in my slides, but I don't think I did.
Yeah, that'd be great. I know Anna shared the slide for our radon topic, but any other links you want to put in the chat would be great. And then I'll make sure to pull those together afterwards. Okay, Jocelyn, if you would like to turn your camera on and unmute yourself and share any questions you have or that have come up in the chat or the Q&A.
Perfect, thank you. And thanks, Kathleen. So first thing I'm going to ask to all the participants, if you have any stories of when someone has come to you and needed some of these resources, and maybe you've had them, maybe you didn't, and you want to tell that story, you're so welcome to do that in the chat. And of course, ask any questions using Q&A. If you think of something later, you can always put it in the Q&A, and we can always talk about that at the end in our larger discussion period. I know we don't have a ton of time right now, so I'm looking through my questions that are, some of them are my own and some of them are from a couple of nurse colleagues as well. Let's see. So, one question I think that maybe some of us have is about whether these housing issues are reported anywhere, whether tenants have the ability to check a repository or a place for, like, say, like common offenders in terms of landlords. Is there any way to proactively try and not be in a building that has these existing issues, or know if they've been resolved or still ongoing, like bed bugs, for example, like mold issues or other issues like that, and kind of issues around that?
That's a really good question. I can't say that there is one place for that, but there are local resources that I would think through the especially through local legal clinics, to find out that, or to find out, links in the individual community. That's exactly the kind of that, plus, other more positive, I guess, measures to address housing, that the Rent Safe Connector tool is intended to enable, or to respond to. But through like local anti-poverty task forces, there's those sorts of community resources, and the people engaged in them, I think, would be the best way to find that out. But to say there's one place for the whole province, I doubt it. It doesn't strike me as the most effective way of getting at that kind of information. But at the community level, I bet there's more, to go on. I hope that's useful.
Yeah, thanks. I think it's just, sometimes you hit that golden window where someone's looking for a place to live. So that's good to know. And just generally about prevention of exposure and ways to limit the chances that somebody is going to, come in contact with bed bugs. And I wanted to, or other health issues. Before I move on to the next question, I think we have a little bit of time. I wanted to mention there was a question in the chat, and it was about responsibility on reserves of regarding safe water. And I'm going to defer that to Theresa, because she's going to talk a lot about drinking water, and I'm sure that audience member didn't realize that at the moment. And we can ask that of her. Maybe one more question. I think you already shared a fact sheet about mold and the health issues that can be caused, like the actual symptoms, signs and symptoms that you can look for as a healthcare provider. And I wonder if there's a place, if that's on the website, where there's other signs and symptoms of common environmental issues.
Yeah, the mold stuff there's a whole section on the rentsafe.ca website with all those resources. And once we have that expert report, it'll be up there as well. We're hoping that's going to be ready by early December. So yes, rentsafe.ca. The bedbug fact sheets on the CELA website, I'll throw the link to that in the chat. I think I put it in the slide deck as well, but I'll put it in there just now. And then RentSafe is just going to keep going. I didn't mention that the next big area we're working on is hoarding. And we'll do the same kind of approach we did with mold. It's come up with those, practical tools for tenants, for physicians, for public health, and just keep going on those kinds of topics.
Awesome. Thanks so much, Kathleen.
High priority topics. Okay, throw the bedbug fact sheet in the chat.
Great. I think it's probably a good time, to move on. Thanks so much.
Perfect. Thanks, Jocelyn. That's great. Okay, so we're getting close to 1 o'clock. What we're going to do is hear from Theresa. We'll have Theresa's presentation, and then we'll take a short break and come back and do the Q&A for Theresa. So you can be thinking about all your great questions for her while you're stretching your legs on break. So I will turn it over to Theresa, and just let Crystal Ann know when you need your slides advanced.
Great. Thank you, April. And thanks, Kathy. I am always appreciate the refresh on this work. Even though I'm immersed in it all the time, it's still always so useful to see what over the years we've put together for people. So source protection and drinking water is another topic we've worked on for many, many years with many, many partners. And next slide, Crystal Ann. So we're going to talk today about lead in drinking water, and we're also going to talk about source water protection. And lead is a really specific issue, but kind of distinct from the rest of the source water protection discussion, because the issue we're dealing with at this point in time in Ontario, and this is an Ontario-centric presentation, so the rest of Canada doesn't necessarily have the same regulatory framework in place. but there is work happening all across the country because of Health Canada guidelines. But what happened here in Ontario is that in 2007, so is that really 14 years ago? Maybe that's 7 years ago. Someone can do the math. The medical officer of health in London noticed that there were quite a few elevated lead levels coming in after they had put leaflets in the utility flyers for people letting them know that lead is an issue, and they had free testing by the municipality if people wanted to get their own water tested, because before that, lead was only being tested in Ontario um, uh, basically in the drinking water main system as it got delivered, but before the property boundary. And because those mains had often weren't lead in the first place, they're larger diameter, not made out of lead, but also had been changed out over time, those elevated results weren't showing up. So full disclosure, this is when I was at the minister's office, and I was pretty shocked to see this because of my previous work at CELA on lead, and I asked our chief drinking water inspector at the time in Ontario what was going on, and he looked into it and then asked municipalities across the province to check at household level at tap in the older areas of the towns, and found out that it was actually quite a prevalent problem. And it had to do with the fact that there were a number of changes going on in water systems, differences in treatment systems, and it was changing things like the chemistry of the water. And maybe previously it hadn't been an issue, but because the chemistry was changing, the lead was being released from wherever it was. And it turned out that where it was typically was in the service lines supplying the house, or potentially in plumbing, in larger systems like schools and the legislature, and so on. So quite a few changes, regulatory changes took place, required testing at the tap on a sort of sampling basis, having the municipality do work on its water chemistry, adding a schools and early childhood and nursery program, for example, flushing, adding program to help low-income households with filters if their own system was an issue and they didn't have the lead service line changed yet. So we went back and looked a few years ago about what had happened since then here at CELA, and realized that things were still quite slow in many municipalities, quite patchworky, which is, I guess, one of the themes of the day. And so many communities lacked public information about how much this still remained an issue. And in our view, and I think this is echoed by the drinking water industry and public health and municipal officials and the province and so on, is that the main remaining reservoir as such of a potential source of lead for drinking water to many Ontarians is the fact that the line between the street and the house, or a part of that line, may still be lead. And this is more common in older houses because after sort of the 60s, let's say, lead wasn't so often used, and rather those were often copper. Next slide. Crystal, next slide. Thank you. So we think the pace really needs to step up. It's way past time. There have been improvements on lead in other areas of our lives. Lead came out of gasoline, lead has come out of paint, lead has come out of products. CELA has been there for a lot of those efforts, but we really don't want to see continuing lead in drinking water, especially for vulnerable population, especially since this can often be the case where people can't afford to change out the lines themselves, or can't prioritize that effort, or they don't know about it, or they're a tenant and their landlord has no incentive to do it. As I mentioned, Health Canada, the Canadian Council of Ministers of the Environment, did recommend a more stringent standard in Ontario for lead. And so it's now way overdue to be adopted in Ontario. Ontario hasn't moved on improving that standard. That would cut in half the standard from 10 micrograms per liter to 5 micrograms per liter. So that's one immediate action that Ontario could just do. Change the standard and make sure that it's 5, not 10. Next slide, Crystal. And then, as I mentioned, this is really an equity issue, because the people least likely to be able to make those changes, often due to limited resources, may be the ones who are the most impacted and may not even know about it. Plus, it's a children's issue largely, not exclusively, but quite an issue for babies and toddlers and children because of developmental impact. And the oversight of the exposure in the different settings like schools and daycares and residences is quite fractured. There was a big series you might have seen across the country led by the Journalists Consortium showing that this issue is really poorly addressed in many jurisdictions, and particularly in Ontario. We still have some of the settings where children spend their time that need to be better addressed. Next slide. So what do we think should happen? We think that, things have moved along kind of on a voluntary basis, how fast municipalities are moving, or whether they're incenting their communities, or whether they're providing public education and helping identify the location of these lines. So we think that needs to be mandated, and with targeted dates and targeted actions, and with public reporting of the progress that they're making. And we think the frequency of retesting the community sampling at consumers tap, needs to be increased, including retesting communities and locations that previously tested fine, because things change over time and then they could get back into trouble. Next slide. And so this is from our one of our recent submissions on lead in 2019. And I'm not sure if we'll have the link, but we'll put it in the chat if one of my colleagues doesn't mind grabbing the most recent submission we just sent to the province this month. But we want the standard cut in half in accordance with the Health Canada guideline. We want publicly accessible inventories about where these lead service lines are in communities, concrete plans to remove them, shared commitments and incentive programs and grants to help the low-income consumers. Of course, continue dealing with the water chemistry, a much better approach to public education, and apply equity and intergenerational equity and precautionary approach principles to the work. Next slide. So this is an example of a good public education tool where in Guelph you can find out what part of the city has the homes that may still have lead service lines if they weren't replaced, which would likely map, April can tell us this for sure, but would likely map against the older residential construction in the city. And then the construction outside of that, it would be less at risk, although I hasten to say that fixtures can still be a problem, including, oddly enough, expensive fixtures, because sometimes they use metal alloys that have lead in them. And so if the chemistry of the water coming into the home is corrosive, then that can still be causing a problem in that home, even if the service line between the street and the house is not based in lead. Okay, so next slide, and I think we'll switch to source water more broadly. Right, so as a principle, we're making this point because there has been pushback about, well, it's the homeowner's responsibility, they own the house, they own to the street. But we argue that most utilities are supplied to the consumer right to the house. The consumer doesn't know it's different for lead. And so we think this issue of ownership and access is among the barriers that need to be addressed and is not an excuse not to be taking action. Next slide. So, source water and drinking water protection in Ontario, we have a multi-barrier approach to protecting drinking water, and this arises because of the tragedy of the Walkerton inquiry. And CELA represented the concerned Walkerton citizens at that inquiry based on our longstanding work arguing for a Safe Drinking Water Act, which we didn't get until after Walkerton, and other aspects of protecting sources of drinking water. And at the inquiry, we argued to much mystification, I would say, on the part of many others, including Inquiry Council and that team for a while, that we needed a multi-barrier approach, and we were supported in this by the drinking water treatment industry once they realized that we couldn't rely on groundwater always being safe in this province, which they had previously thought was the case. So now we do have in this province a pretty strong safety net approach where we don't just rely on the treatment at the end of the day. We're also testing, we're looking at the distribution system, we're looking at the source of water, we're looking at the certification of the operators, we're looking at reporting and oversight with health and environment. And it's quite an in-depth approach, which is really essential to something as critical as safe water. And we do advocate that kind of an approach across the country. Not every jurisdiction has adopted this yet, including for First Nations. It's an aim for First Nations systems, at least as reflected in a variety of contexts, but it hasn't been fully adopted yet, or at all in most places for First Nations. Next slide. So for source water protection, which is the sort of the first barrier in that cycle where we're saying it's a lot easier to protect drinking water if we can keep the source clean in the first place and not have to deal with a contaminated source after the fact. We have, as I mentioned, a good system in Ontario for municipal water, municipal treated water, that's within what we call a source protection area. And a lot of the province lives in such an area, as indicated with these statistics. However, we still have a considerable number of people, hundreds of thousands of people, in rural, remote, northern, eastern municipalities and outside of municipalities, as well as First Nations communities, who are not protected by a source protection plan, or who are on a municipal system but are not living in a source protection area. Next slide. So we have these gaps, and that's one of the things CELA is trying to draw attention to at the moment, is that these gaps were meant to be addressed when Ontario adopted its multi-barrier approach to protecting drinking water. There was prioritization around municipal drinking water and areas that were consistent with our conservation authority boundaries in the province, which are many of the big populated areas in the province. But it was always intended that we would have other approaches that could provide source protection for everyone else, including around vulnerable aquifer mapping, for example, including around bringing the non-municipal wells into the system. For example, down where I live in Brant County, almost all the towns in my county, except for St. George and Paris, do not have municipal water. So there might be several thousand people living in the community, and they're all drawing from similar aquifers, but there's no source protection for their wells. So this was intended to be addressed, and it's now been actively discouraged by the Provincial Ministry of the Environment. And then the third gap is First Nations communities who do have a tool within the source protection legislation in Ontario to bring their systems into the Ontario system, but most have chosen not to do that. Only about 3 have chosen to do that. So CELA has been working with a number of First Nations communities to develop source protection toolkits that they could apply. And we, of course, are also advocating for improvement on the federal legislation and resourcing and I can address that more if people have questions. And finally, I mentioned that there are municipalities that aren't covered because they're not in a source protection area, and that includes quite a number of municipalities in eastern and northeastern Ontario with quite a cumulative population where they have a treated system, but they don't have a source protection plan in place. So nothing is looking at their source other than monitoring their actual intake right at the plant. And the point of source protection is to go further upstream, whether it's surface or groundwater, and make sure you're not letting contaminants get anywhere close to the plant. Next slide. And this is a map showing where are the source protection areas and regions, and you can see how many areas in northeastern Ontario, northern Ontario are left out. And then even within that lovely colored area in the southwest and those particular areas in the north that have source protection areas, again, it's just the municipal treated water systems in those areas that are covered, and not the hundreds of thousands of people who aren't in that particular context. Next slide. And then there's another category of protection where we have small systems. So this could be a kids camp, a rural gas station, this kind of thing, where they have their own water supply. And at first they were going to be regulated the same as municipalities, and it quickly became evident back in the day that this was quite impractical. And so CELA met with Ministry of Environment officials and advocated that we needed a more specific, focused, risk-based approach to these systems, as a result of which they are overseen by the Medical Officer of Health under the Health Protection and Promotion Act, where they would address their source and if they need any treatment. And then if not, they'll have to post the water as not potable and have another supply, obviously, if they have residents at a camp or a senior's home or something. And then for the rest of the systems, they're overseen by the municipality with oversight responsibility by the Ministry of Health and Local Health Unit and the Ministry of the Environment. Next slide. And I've already mentioned that many Ontarians rely on their own wells, and this is not just single farms out in the country as you might picture, but it's First Nations, it's municipalities who have well water for their treated system but don't have source protection. It's people in communities like my neighbors in Burford who all have their own well, and then they also all have their own septic system, and they also have surrounding agriculture and surrounding industry. So one example that came up in the past was that in Southwest Ontario, because we have sand and gravel, aquifers and agricultural activity, nitrates have been gradually increasing, and this is causing a great concern to the municipal systems drawing from that water, because most of us are groundwater supply in that area of the province. Oxford County, Brant County, Norfolk County, etc. So the nitrates are increasing, and this is a serious health issue where, for example, infants maybe shouldn't be using bottled water if the nitrates are high because of a link to SIDS. And yeah, Waterloo too, Elgin, all over the place. And then, but other individuals with other types of health conditions can also have risks posed by nitrates. And so when we don't have source water protection, we don't have an assessment where somebody's looking at the context of that water and then giving advice to the surrounding community where a particular contaminant is of concern. And where it's been brought to the health unit's attention, often it's just based on individualized residents bringing their water in for testing. Next slide. So I think this is where Anastasia wants to take the reins back and give us directions, but I'll just wrap by saying that like the topics Kathy covered, this is years and years and years of collaborative work, bringing science to bear, making evidence-based decisions, and then arguing for the legal tools that can help protect our population. So I'll stop there.
Thank you so much, Theresa. Okay, as promised, we're going to give everyone a 5-minute break right now. I'd love if we could keep it closer to 3 minutes instead of closer to 10 minutes. So if we could bring everybody back in 3 or 4 minutes, but we will start by 1:20 at the absolute latest. But go ahead and take a moment to stretch your legs and move around a little bit and think of great questions for Theresa, and we'll come back in just a few minutes. Thank you. All right, it looks like we have at least Theresa and Jocelyn back, so we can get started on Q&A. We'll take about 5 minutes for the Q&A here. Go ahead, Jocelyn. Jocelyn, I think you're still muted. Can you hear us? Theresa, can you hear me? Yes, okay. Wanted to make sure it wasn't me not making any noise. Wondering if Jocelyn's headset isn't connected.
April, I'll start with the first question that just came in on the Q&A, asking me to expand on the work CELA's done to get federal government to get clean water to northern communities, and in particular First Nations communities. And there are a few things we've specifically done. One is that when we were engaged in the source water work in the wake of Walkerton, and we were sitting at community stakeholder tables to come up with solutions, we were very engaged with, for example, the Chiefs of Ontario and the Ontario First Nations Technical Secretariat and federal and provincial governments about coming up with a system that would work, that would include everyone. And then when I was wearing my hat in the ministry working on Walkerton, that's right when the source water legislation went through, and that included a way for First Nations to get involved that would oblige the province to help protect First Nations water through source protection plans. But like I said, only about 3 First Nations communities have gone in that direction. I can certainly spend time with any who want to know more about that. So then we've worked with the Law Foundation of Ontario, with Tides Canada, which is now Makeway, on a number of projects in Pays Plat, in Grassy Narrows, and in 3 First Nations on the Thames, Chippewas of the Thames, Oneida of the Thames, and Munsee, Delaware, to develop First Nations source water protection toolkits about if they aren't in the provincial system, what can be done to identify some of the threats immediately and take some action. We've also been invited by the Assembly of First Nations to attend workshops across the country as they come up with a new approach to replacing the First Nations Safe Drinking Water Act, which none of us like at all. First Nations chiefs don't like it, the associations don't like it, CELA doesn't like it. So to come up with a new approach that would be much more robust. And Anastasia just put the collection in the chat. Thanks.
Perfect. Thank you, Theresa. And we have Jocelyn back. So Jocelyn, if you want to go ahead with a question or two, we have about 3 more minutes.
Okay, great. Sorry about that, everyone. Let's see, I'm just reading some of the things in the chat, and I see about why the question that relates to, I think, what you said, maybe it's a clarified question as well, about why First Nations would not advocate with you for that source protection. Like, why would they make that decision or go that route?
Oh, so yeah, there were various reasons that First Nations have made that decision or not made that decision in their own community. Those who have opted to use the provincial tool, and so the provincial legislation, because First Nations are not, constitutionally within provincial jurisdiction, we can get into a whole other discussion about Indigenous law and how it's not very well reflected and recognized in Western law. But in terms of, legislative capability, the province certainly cannot pass legislation that directly affects First Nations adversely. The laws of general application can apply. So that's why the legislation, said if a First Nations community with a treated water system passes a resolution to be included, they can be included. So the ones who have been those who had long, in my observation, have had long-standing relationships with surrounding municipalities in managing the water that's going through all of their communities. So for example, on the Grand, Rod could speak to this, he's on the call, I think, is that there was a long-standing notification protocol up and down the Grand way before Walkerton, way before source water protection, because everybody relies on that same, major tributary, and all the communities were already engaged in helping each other that way. So whereas in other places there wasn't that long-standing relationship, and so the perspective was they might not have wanted to have the province getting engaged in decision making around protecting their water on reserve. In my view, it's an extra tool. It's a good one because it forces the province, surrounding municipalities, and surrounding landowners to have to take action. If a threat is identified to that system, it becomes mandatory. So it's just an extra tool, and it's at the option of the First Nation whether to use it. So that's just a quick answer.
Thanks so much, Theresa. I know we're running short on time, so there's a couple of thoughts, and let's move those to the Q&A period so we can discuss those then. I'll send it back to you, April, and then Fee.
Thank you so much, Jocelyn. It's always this debate of we have all this great information to present and we want to have time for that, but we also really want to hear from everyone on the line and answer all the questions. And yeah, you wouldn't have shown up if we'd asked for 4 hours. So we're going to do our best to balance off all those important pieces. Okay, so our next presentation today is from Faye de Leon. Faye is a researcher and a paralegal with CELA. Faye holds a master's degree in public health. She has worked extensively on toxic substances, particularly in the Great Lakes Basin, on the Federal Chemicals Management Plan, and on international efforts, including the Stockholm Convention on Persistent Organic Pollutants, the Great Lakes Water Quality Agreement, and the Minamata Convention on Mercury. She has coordinated efforts of Canadian NGOs on various matters that include seeking a ban on asbestos in Canada, reviewing the Canadian Environmental Protection Act, and improving the National Pollutant Release Inventory. And I know that Faye's Wi-Fi is being nice and glitchy for her today, so she's on the phone. And so Crystal and Faye will just let you know when to advance a slide, and we'll let Faye know what slide we're on so that she's speaking to the right content. So take it away, Faye.
Thank you. Can you hear me, April?
Yes, we can hear you.
Yes, fantastic. Okay, Crystal, if you could advance the slide to the outline. Okay, and I've been asked to, thank you. I've been asked to talk about right to know access to information. So I'll just give a general context, a little overview, and I'll go into the discussions around right to know, transparency, disclosure, labeling, and some information around public participation. Next slide, please. So in terms of context, we heard from Kathy in terms of impacts associated with toxic chemical exposure, particularly food products, and certainly the importance of that in terms of children, particularly children with low income, and the increased risk to them. What we know in Canada is that we have thousands of chemicals already in the market, 23,000 plus and growing. We know that there's 500 to 600 new chemicals being introduced every year into the market as new substances. From CELA's perspective, we look at looking at toxic chemicals and the management of chemicals mainly through a life cycle approach, when we think about extraction to production, manufacturing, and then ultimately managing it at end of its life or, possible disposal. Those issues come to mind when we think about how we look at toxic chemicals. We also know that at CELA, we do try to promote a precautionary and prevention approach to this work. And certainly one of the reasons why I raise that is because it speaks to the type of information that you need to be able to advocate for that. In Canada, generally the approach has been to, when the government has the authority to manage chemicals, they do it through the lens of generally taking a risk-based approach, which means they look at the hazards and exposure information that's available for those chemicals. We tend to try to elevate the importance of hazards when it comes to certain chemicals, some of which Kathy mentioned in her presentation. We do know that many chemicals that are found either emitted through industrial processes and or products are associated with scope of health and environmental impacts. And we won't get into that until we on a later slide. I do want to just emphasize that Kathy's presentation on impacts to children, particularly to the developing fetus, is really quite critical when it comes to identifying vulnerable groups. We talked about the inequities associated with people who are of low income status, but there are other vulnerable groups that we try to capture and certainly use to demonstrate where there's a problem with what we're facing with toxic chemicals. And these include workers, particularly Indigenous communities, and certainly racialized communities, as we're seeing now as certain focus and the need to address those challenges. Next slide, please. So in order to be able to advance and advocate for change in our system, one of the things that we think is quite important is just being able to have some information to be able to engage and to know what the problems exist, the problems that exist. We call this, access to information or right to know regimes. In Canada, we have what they call a national pollutants release inventory. It's the main inventory by which industrial facilities that meet a certain criteria are required to report to the federal government. That mandatory requirement is stipulated under the Canadian Environmental Protection Act, which is Canada's main environmental law. Why it's important that this particular inventory exists is that it does track and requires reporting on over 350 sold chemicals, including criteria air contaminants, which could be associated with a range of respiratory issues, including asthma. The government currently collects this data on an annual basis and makes it available to the public and in different forms. So you could do searches and it allows individuals to look at the information on these chemicals for their particular community. It allows researchers to also use that information to determine whether things are getting better or worse when it comes to air quality or water quality, for example. And one of the benefits of having this information available as well is that it also sets up the government as well as even NGOs to determine where there could be a policy, an environmental policy response, or to support the need for regulatory changes. Next slide, please. So the next slide outlines a map of Canada, and you see a whole bunch of dots, which represents all the facilities in that report to the National Pollutants Release Inventory. Currently, there's about over 9,000 facilities that meet the criteria for reporting. So if you click on any of these dots, you can actually get a profile of that particular facility and the releases to air, water, and land, or transfers to off-site. So it's quite an interesting tool that's available online, that's available and accessible to anyone who has access to the internet, and you can do different searches. So I'll demonstrate to you in the next slide, if you can just switch over to the next slide, President. in terms of search function. I just took a screenshot of what the MPRI data search looks like currently. It's quite small, but it allows you to do a quick search for anyone who's interested in looking at their community, to just punch in your postal code. And then based on that, could track which facilities are actually relevant and are found in your community. Other searches you could do with that is just do a quick sector search, right? If you're interested in particular facilities in your community, you know the name of that, you can do a search on that. Why I think that's critical is that it allows people to create some sense of what kind of emissions, whether it's to air, to water, or to land, is relevant for your area. Some of those chemicals, as you know, are very much associated with certain health effects. So if you're concerned about a local facility, certainly this is one tool that you could use to search out that information. What FEMA has done over the last over a decade at least is use that data in different ways. One is, so I've provided a chart, which you can barely see, but at least a list of chemicals that are on the side of one of the chart table, a list of chemicals that are reported under the MPRI, but may also be relevant when it comes to promoting changes to the law. So we've used this particular data set to inform government on what changes needed to be made to environmental law. And we're in the middle of doing that now. The other area where we've used the data is to add it to another set of data sets that we've looked at, including income data, to be able to map where in Ontario, specifically more in the Great Lakes Basin, where there's high levels of pollution using the MPRI data and high rates of pollution, poverty rates. And in those cases, that work was done in 2008. What we ended up doing with that research work was to identify where CELA could best place some of its resources to reach out to those communities and share the services that we do have, and to start up a discussion in terms of what could we do in light of the fact that there are facilities that report high levels of air pollution into their community. So there's different ways of using that data. And certainly one of the things that I want to mention is that that particular website at the moment doesn't include any information on health effects, which is kind of unfortunate, but clearly the government website connects to those types of information on their site. So there's ways to get around that. If we can advance to the next slide, Crystal. And I just want to share, this is the right to know regime for Toronto. Similarly, what the City of Toronto has done is actually passed a bylaw called the Environmental Disclosure and Reporting Bylaw that also collects data. And there's a little bit of overlap with the National Pollutants Release Inventory, and that some of the facilities that already report to the MPRI may also report under the ChemTrack data. And the reason being is that this particular right to know regime actually collects data on 25 carcinogens that are relevant for facilities in the City of Toronto that meet a lower threshold for reporting. So the benefit of that is to get information from facilities that may not report under the bigger program under MPRI, but gives you a different perspective on the issue. So some of the facilities that may be reporting under this program may include dry cleaners. They wouldn't be captured under MPRI, but there are smaller facilities that use certain chemicals, emit certain chemicals that are required to be reported under the ChemTrack process inventory. Similar to the MPRI, you could do mapping, look at the maps, see what facilities are in your neighborhood, and be able to understand the impacts of those possible impacts of association with health effects, because this particular website does include information on health effects. So those information is quite relevant when you want to start out the discussion with your neighboring community, neighboring facility. It also gives you additional information on how best to reduce your exposure to these types of chemicals. Next slide, please. So, moving away from particularly a focus around releases to the environment, air, water, and land, I just want to shift over to what other type of data could be included or should be accessible to the public when it comes to toxic chemicals that may be associated with health effects. And I guess one of the biggest issues that's come up for us is, there is limited transparency when it comes to information that is available out there. We've seen a real shift on the focus around industrial releases of chemicals to the community, to a focus around the chemicals that you normally wouldn't consider as being problematic, but are found in everyday products. So toxic chemicals that was mentioned in Kathy's presentation, like the flame retardants, for instance, or the polyfluoroalkyl substances that are now emerging as a real concern, class of chemicals that are a real concern because they're used extensively in consumer products for the water resistance and stain resistance properties are found in a host of chemicals. So do we need access to information that goes beyond industrial releases? And I think the answer is yes. Do we have it? The answer is in very limited fashion. So when you think about some of the health effects that are associated with those chemicals that are now being found in everyday consumer products and are being released over time into the indoor air or even outdoor environment, it's worthwhile being able to track that, monitor that, and to use that information to inform what other regulatory responses is required. There is a host of information already out there that could help fill in some of that gap, but it's incomplete. So we don't have a lot of requirements when it comes to labeling products for many of these chemicals. But what we do have, which is not a solution, but certainly one of the areas where you can look is Health Canada manages what they call a cosmetic ingredients hot list. At least identifies some of the chemicals that are known to harm human health that may be restricted or prohibited in certain cosmetic products. So that's one source of information. We also look at biomonitoring data that's been coordinated by Health Canada to determine what kind of chemicals are we finding in humans, whether it's through their urine or blood tests. And Health Canada has undertaken several cycles to collect some of that information. But there's certainly other biomonitoring data that helps inform what you do with chemicals when it comes to children's health and maternal health. That's critical. And there's also, that's complemented by environmental monitoring data that are developed in cyclical fashion for various areas in the province as well as across Canada. So the limitations with those types of programs, though, is that they're very limited and scoped to certain chemicals. So you have to negotiate which chemicals are dealt with. Lead and mercury are chemicals that are often looked at, other heavy metals as well. Phthalates, because they're used extensively in plastic products, are also a focus of these types of monitoring programs. I'll just mention the workplace, and there's certain data that needs to be collected and be available to workers in the workplace. That includes the material safety data sets, as well as WIMIS providing some information on chemicals that are used on site. So those are accessible. And I'll just point to the fact that there are other standards that have been established because of that information that's been collected. They're certainly not all comprehensive. There's certainly needs opportunity to improve on those standards, but that requires data to be collected and be available to push for those changes. And if you just want to go one slide forward, Crystal Ed, I'll just so I'll just can you hear me?
Yes, we can hear you, Faye.
Oh,
yeah.
Sorry about that.
That's okay.
Yeah, so if you can go forward to the next slide. I just included the exposure pathways for two particular chemicals that we've been focused on, or substances, products, materials, and just to demonstrate where there is exposure to humans. So the left side talks about actual plastic waste. And so when we think about life cycle approaches, as we do at FEWA, we look at possible exposure from extraction process to manufacturing, and certainly the use of consumer products, and ultimately at the end of the process, when you think about the waste that's associated with plastics, there's varying degrees of exposure to humans that are relevant, and certainly is important, because when you think about the fact that these are not the only things that you're exposed to every day, you're exposed to multiple products, multiple materials. There's different routes of exposure that we should be just concerned about. On the right-hand side is exposure route for humans, particularly from a group of chemicals, the perfluorinated chemicals that I mentioned earlier, that are now used extensively in products and are found to be found in our at least Canadian population. Over 90% of the people have this in their system. These chemicals are quite. There's about 6,000 of them in a class. So the problems are not well known in terms of where they're found in Canada, but certainly from the perspective of potential impacts to health, there's different routes of exposure from products that could ultimately impact human health. Next slide, please. And I'll just and just closing off, opportunities to use that information for the public, and certainly for us as an organization. The issue around public participation is really quite critical in all of this. Access to that information and buildup of that information allows you to at least access the decision-making process. There are legal frameworks that point to areas where you could share your knowledge, at least provide information on particular chemicals that are subject to assessment or evaluation and management by the government, and certainly if there's proposals for expansion of facilities in a community, some of these sources of information may be useful so that you could actually engage in those discussions. So the Canadian Environmental Protection Act and Environmental Bill of Rights in Ontario are key areas and key regulatory frameworks by which there are some opportunities for public access and public participation. And I think that's it.
Great. Thanks very much, Faye. And well navigated despite some Wi-Fi challenges. Okay, at this point, I am going to invite Jocelyn as well as Lisa to turn their cameras back on. We have sorry, I have a cat trying to join the call. We have about 10 minutes or so left before we want to wrap up, maybe 11 minutes. So I will turn it over to Lisa and Jocelyn at this point.
Thank you very much, April. I'm sorry, I'm just trying to get my Zoom going again here. Amazing presentations. Thanks so much to all three of you for all that information. Before I go to Jocelyn with some questions, I just wanted to check in with the audience. Are there resources that you need when it comes to helping you with the work that you are doing? Things that we haven't covered today, topics that would be of interest? we're very curious to hear from you how we can support the work that you're doing. So if there is anything, please feel free to put that in the chat. And there was a question here in the Q&A about whether CELA and CALC is doing similar research and work in provinces outside of Ontario. So I can answer the part about CALC, and then I can turn it over maybe to Theresa if you'd like to take the part about CELA. So Ontario is actually really uniquely positioned as one of the only provinces that has a legal clinic system set up the way that we do. So there are other, in the other provinces, there are ways to get free legal advice and information, but it's not generally through community legal clinics that are embedded in the communities, and certainly not this geographic system that I described earlier. So there are justice and health partnership projects that are taking place. Those are mostly outside of Ontario, being done through law schools at the moment. But it's something we hope to see grow across Canada as time goes on. And Theresa, if you want to take the part on behalf of CELA.
Yep. So in terms of CELA, while we're core funded as an Ontario legal aid clinic, federal law and federal activity also affects all Ontarians and everyone else across the country. And there are quite a few things we do. So for example, a lot of the work Faye was describing, the National Pollutant Release Inventory, is under federal legislation. The Canadian Environmental Protection Act, which sets that up and deals with many other aspects of chemicals regulation, is under review. Law was introduced just before the parliamentary elections. We expect it to come back. Similarly, we collectively belong to the Green Budget Coalition, where we advocate annually for where resources should go, and we advocate for First Nations drinking water and housing. We've been advocating for an Office of Environmental Justice for quite a few years. We're working with a national coalition. Faye is involved on environmental racism and equity. And as I mentioned, we're working on a replacement for the First Nations Safe Drinking Water Act. So there are several examples, and if my colleagues have others, then you can maybe add to that or add them to the chat.
Great, thank you. All right, so if anyone has any questions for any of our presenters, feel free to put them in the Q&A. But let me just check in with Jocelyn to see if you had any on behalf of the healthcare providers.
So I've been, thank you so much. I've been thinking about like these exposures and the many possible exposures to chemicals. So this is for Faye. I wonder if you can speak to the issue of continuous and long-term exposures and chemicals that interact with one another.
That's a very good question. And it's an ongoing issue that Kathy might want to add to it as well. So that is a subject of real concern for folks, because a lot of the chemicals that we're seeing tend to be at low levels, right? So the issue around cumulative impacts, and certainly chronic, as it relates to chronic diseases over time, is an issue that's well under discussion at the moment. The system itself, like the way that we look at chemicals, particularly in Canada under the Canadian Environmental Protection Act, we are still relying on a risk-based approach, which means that information as it pertains to chemicals are generally collected based on available data. But there are components in that legislation that allows you to ask for data. So when we think about cumulative impacts and long-term effects, issues that we are most concerned about are around those chemicals that may be considered endocrine disrupting chemicals, and because you don't see impacts until very late in the development of a person or wildlife species. But that the body of studies that are demonstrating the need to take that into consideration is growing, right? And so, but the regulatory response as of yet hasn't come to the point where there's a clear path to say, these chemicals need to be addressed right now, as opposed to wait until more information is available. but it is a subject of discussion in the review of the Canadian Environmental Protection Act, and particularly as it pertains to how it is to impact the specific vulnerable groups, particularly children and workers. Kathy, I don't know if you want to add to that.
Sure. I can't start my video. It's been taken off. I don't have the ability to do that. Anyway, it doesn't matter. Oh, there it is. It made me think of the work we've done on getting pesticide bylaws in place, bylaws to ban the cosmetic use of pesticide, or cosmetic or unnecessary use of pesticides. And one of the strongest rationales that we use for that, I think one of the most logical, is in a world of multiple chemical exposures, we can and should reduce those exposures that are unnecessary. So those have been wins over the years, good wins in Ontario in particular, municipalities, and then at the provincial level. And recently we've been harnessing the work of summer students to help us, or to help organizations in other provinces in their efforts to put in place pesticide bylaws. We do need to stay within our provincial mandate. That's where our funding comes from. But it is an illustration of an area where we've been successful in policy areas to address multiple chemical exposures. And with that argument that, if it's not necessary and we've got all these other exposures, we need these bylaws. And that's applicable in other areas as well. But anyway, if people want more information about that, especially from out of province, there's lots of it on our website. So that's just what I would add.
Thanks very much, Kathleen and Faye. Anybody else want to add to that question from our panel? Okay, all right. Jocelyn, anything else for us?
I don't know a lot about it, but I know that somebody a while ago mentioned in the chat an emergent chemical of concern called strontium. So I was wondering if anyone had any thoughts on that, just to pay some attention to that comment on what's going on with that, if that's a chemical of concern that you've noted.
So the issue is strontium in drinking water. So the issue of radioactive substances, so there's an isotope of strontium that's radioactive, is very problematic because historically the radioactive substances have had drinking water standards set at what we consider are very high levels of exposure. They use a kind of a completely different framework to set those. And work that's been done in the past has estimated that with the standards that are typically set, they're about 70 times lifetime risk of inducing cancer or being effective carcinogens because of the framework used to set radioactive substances standards in drinking water. But some of them have started to be reduced somewhat. And so there's an example of a recent CCME consultation reducing the strontium standard. In terms of where it's found and to what extent it's in background versus industrial, I'm not sure without starting to look into some of those reports.
Thanks, Theresa. Okay, well, we've only got a couple minutes left here, so I will maybe hand it right back over to April for any last comments before we say goodbye.
Great, thank you, Lisa. Okay, so I just want to reiterate, I wish we could all be sitting in person around tables and we would get to see all of your faces and hear about the work you're doing. It's so lovely that webinars make this more accessible and we can all do it from 2 hours at our desk. But it would also be great to be in conversation with all of you. So don't think of this as the only opportunity for us to engage. We wanted this to be the start of a conversation. So there's a link to a survey in the chat box. It should pop up when you close your Zoom webinar in a minute or two, and we will send it to you by email. So that's a chance for you to also tell us, it was great to hear about that fact sheet on mold. I'd really like to get it. I don't have the link. I need more on this. My patients are tenants who are dealing with this kind of mold, whatever it might be. Let us know. If we have it, we'll share it. If we don't, we'll see what we can do. So we are going to be following up with an email to everyone who registered. That will have the recording, it will have the decks, it will have any links that have been shared in the presentations, in the chat box, in the conversations. And if there are any additional resources that our presenters think would be helpful to you, we'll include that as well. So you should get a whole package of stuff from us after today. But please do take a minute to fill out that survey if you have any thoughts that you didn't have a chance to share today or that come to you after the forum. I'll also note my email address is on the screen here. Please feel free to drop me a line if you want to be connected to any of our presenters. I think that's probably easier than putting 9 email addresses on the screen. So just drop me a line and I'll connect you to anyone that you have questions for. I think those are all of the things that we needed to say in closing. I'll just pause in case any of our panelists have a last word or thought or anything that I missed. But I'm seeing head shaking, so I think we're good. So I will just say thank you so much to everyone in the audience for taking the time to participate today, and a really big thank you to Lisa for co-hosting this, to Jocelyn for participating today, and to all of our CELA staff for sharing your knowledge with us today. Thanks everyone so much, and enjoy the rest of your afternoon. Take care.
Hi, everyone.